his 30 years in academics, Dr. Derksen's many activities included collecting, analyzing, and reporting data to inform legislative and regulatory policies. The intent was to increase health insurance coverage, reduce the number of uninsured, narrow health disparities, and ensure a well-trained and distributed health workforce to meet both the state's and the nation's needs. Tonight, Dr. Derksen will share with us what he sees as the current state of rural healthcare in Arizona and the country.
Well, good evening, everyone. Great participation this evening. Really nice to see that. My name is Dan Derksen. I'm a family physician by training. I grew up in Arizona. Went here for both my undergraduate here in Tucson at University of Arizona and my medical school, and then wandered off to New Mexico where I did my family medicine residency and stayed on the faculty there for 25 years. And returned to Arizona, came back home 13 years ago, and I currently work at the University of Arizona directing the Arizona Center for Rural Health, which houses our state and federal designated state office of rural health. Every state has a state office of rural health. In our state, we're one of 10 states where it's outside of a state agency. So I'm going to launch right in. I want to talk about what I prefer to call HR1 because I don't think there's anything big and beautiful about this bill. So OB3 is the other one that people have been using, but HR1 is the one that was basically signed into law July 4th. And of that 870-page bill, these are the 17 pages that I actually like. And the rest, I got to say that has a lot of bad news for us. But I want to focus on the good news for a moment and start off with that. And I wish I knew who wrote this provision because it's actually quite good and it's a huge opportunity for Arizona. And it's called the Rural Health Transformation Program. And so it's in Title VII, Section 71401. If you want to read those 17 pages pretty quick. If you want a shortcut, I'll provide a link to our Center for Rural Health website where we have developed a Rural Health Transformation Program toolkit for Arizona. This, at least in the bill, it says that it's allocating $10 billion a year for 5 years, half of which is divided equally amongst the states. So that's $100 million per state. So Arizona, if it submits its Rural Health Transformation Program plan on time and it gets approved by CMS, that's something that we can look forward to really help prepare and transform really our rural health infrastructure. The notice of funding opportunity went out by the Centers for Medicare and Medicaid Services just on the 15th of September. So this is a relatively short time ago. It's about 125 pages. In the notice of funding opportunity, states can use, their narrative can only be 60 pages. So there's 2 pages of instructions for every 1 page you can provide back information, which is not unusual for CMS. This notice of funding opportunity went out from CMS to every governor's office, and then the governor decides in each state who will oversee the process of the state determining the submission of their plan. Only one plan can be submitted per state. Megan Kramer, who's a JD, a lawyer, is overseeing the process for Arizona, and they are already engaged in a stakeholder engagement process. So that's gone out through the state Medicaid program, the Arizona Healthcare Cost Containment System, Access. They have posted publicly a request for information from various entities to provide them input and information about that. And we've been doing that as the State Office of Rural Health for Arizona, posting various policy briefs that we think could help the state submit a very strong proposal, because not only do we want to make sure we get that $100 million a year for 5 years, assuming the continuing resolution keeps the government open at the end of this month. By the way, that expires September 30th, so they just have a few more working days before that happens. But assuming the CR goes through at some point, this is This funding is under discretionary funding, so this would be under that continuing resolution. States really have a very quick turnaround on this. This is a big deal, so they have to get it in by November 5th to CMS. And then CMS has a very tight turnaround for 50 state proposals to approve or deny a state's plan by the end of December of this year. So I mentioned that there's another 5 billion available, and that will be distributed by CMS on the basis of, kind of the numerator and denominator data. For example, Arizona has about 11% of its population that's rural. And how many individuals does that represent compared to the denominator of how many rural in the country? How many rural hospitals do we have? How many critical access hospitals? How many federally qualified health centers that serve rural areas? Those are the types of criteria that will be used for that other half of the allocation that was detailed in this provision. So this is a screenshot of our Arizona Center for Rural Health, and I encourage you to go on it. We try to make it very easy. The landing page has this toolkit on it, and you can go to what is that notice of funding opportunity. If you want to look at the form that the state Medicaid program has posted, the access program on the request for information. We gave an overview of those 17 pages, the Rural Health Transformation Program policy brief. And then kind of as you go down, you can see a map there. You'll see another image of that. But we try to post each year and update what we consider the rural health safety net around the state. We only have 15 counties in Arizona, and once you get outside of the main metropolitan areas of Greater Phoenix and Tucson, pretty much the rest of the state's pretty rural. And even Maricopa and Pima counties have significant rural components to those very large areas. We talked some about, the federally designated critical access hospitals, and as we develop and post these, we hope it'll be useful for both the state to send in their Rural Health Transformation Program plan, but also for those interested in providing feedback and information to the state of Arizona as they develop the plan, tools to help them better understand where the needs are, who's currently doing the work, where they're located, and all those types of data elements. I show this slide when I talk to folks from back east, and this is a time of year where we start getting a lot of folks that enjoy our weather and our opportunities here for recreation when it's warmer here and still pretty cold, or getting very cold back east. Just to show the overlay of Arizona, we're the sixth largest state in land area. And of that very large area, 27% is tribal lands. So we have 22 federally recognized tribes in Arizona. We share 370 miles of border with Mexico. And so it's very important for our economic well-being, but also for our guest workforce that really helps us bring in the crops and help take care of the cattle and the other industries that we have. So this is an important component of where we live and how we earn livings and things like that. So about 60% of our population lives in Maricopa County, about 4.6 million of our 7.6 million population currently, and another just over a million here in Pima County. So that's kind of an overlay. We are 14th in population of the state. So people forget sometimes how quickly our population has grown. We've been a top 5 state for population growth, almost twice the rate as the United States overall in our population growth. Now, to get to some of the parts of the HR 1 that I really find difficult to accept. And one of them is, one of the things I worked on when I worked for Senator Bingaman, the 5-term senator from New Mexico, was we worked on really trying to expand coverage. And I was a Robert Wood Johnson Health Policy Fellow. And one of the things we worked very hard on is how to reduce our uninsured. In New Mexico and Arizona, At that time, about 1 in 5 of our population was uninsured. We have done a remarkable job in having our uninsured in Arizona. That progress is not, to me, diminished in any way. We've really done a wonderful job, and we had a record number enroll this last January in the Affordable Care Act marketplace. Part of the reason for that is the tax subsidies that made it much more affordable for people across the spectrum. Those will expire at the end of December, and a lot of us are very hopeful. And I know there's a big push federally to include extension of those tax credits that make Affordable Care Act marketplace more affordable and extend those. That's a real battle right now because the other side really doesn't like any aspect of Obamacare, even though it has had the uninsured in many, if not most of the states, at least the 40 states who have expanded Medicaid, for example. Um, and what, by my analysis, that about 150,000 Arizonans will lose coverage in the next calendar year, starting in January, if they don't extend them. And I think it's not looking so great for them to extend those advanced premium tax credits that make the Affordable Care Act marketplace premiums most appealing to individuals. And just a reminder, I mentioned this before, the continuing resolution that currently funds the federal government expires just in a couple weeks here, in less than 2 weeks, on the September 30th. So the government shutdown will occur. And I think if there's any year in which a government shutdown occurs, this could be one of those years. And that creates a whole host of issues. There's a lot of places like the VA, the Indian Health Service, and others that are under the discretionary side of the budget. When there's a government shutdown, it makes it very difficult for places like that to stay open, in addition to a number of the other things that happen that are on the discretionary side of the budget as opposed to the mandatory side, like for Medicare and Medicaid. Um, Kaiser Family Foundation, the KAFF, if you look at their website, and I've included where these websites are available if you want to do your own sleuthing around, has estimated how much premiums are likely to increase by state. And when I looked at it, it looked like they'll double or triple in many areas of our state. And the health insurers that do marketplace plans, but also do Medicaid, managed care, and others, are already having to prepare what their premiums are going to be for the coming year. Remember, the open enrollment period, which has been dramatically shortened, and the number of navigators assisting people and helping determine if they're eligible for something and enroll, that budget was cut by 90% by this administration. So there's going to be less support. The open enrollment period has been dramatically reduced in this new administration. And so I believe that this estimate for the number of people who lose marketplace coverage is pretty close. And then I think the devastating thing for Arizona is really the cuts that have been put into place in this bill to Medicaid. So our Arizona healthcare cost containment system, I looked as of September 1st, our enrollment is just under 2 million, 1,930,899. That number's been going down since the public health emergency ended and the redetermination process was put back into place. We've lost over 500,000 since the peak of enrollment in Medicaid. So that occurred before a lot of this stuff. So if you look at it from an insurer perspective, they lost 500,000 customers over that period of time. The Congressional Budget Office estimated that this will be a reduction of about 34 billion over 10 years just for Arizona. And by my calculations, that we'll lose about 250,000 to 450,000 of that almost 2 million that are currently covered by Medicaid. So in the combination of that, if you look at it by 2027 to 2028, my estimate is that we'll lose about 1.25 million people who are currently insured by Marketplace or Medicaid. And this will have a devastating effect on especially our rural health safety net, our critical access hospitals, our federally qualified health centers, or rural health clinics, and also the Indian Health Service and the tribal operated sites. And this is this is a rather dense slide, but I just want to walk through. It may take me more than a minute and a half, but who benefits most from HR1? And this is what I call the reverse Robin Hood mathematics. The top 1%, if you qualify in this, the threshold for that is 916,000. If you divide that by a normal working year, that's about $440 an hour. And that at the federal poverty level, you make about $7.50 an hour. The tax benefit to the top 1% of income over 10 years, the Congressional Budget Office estimates is about a trillion. And guess what? The quote savings, I believe that you don't really save money by throwing people off health insurance coverage. You shift the cost to someone else. The savings, the Congressional Budget Office, of these Medicaid cuts over 10 years will be almost a trillion. The average tax benefit to that top 1% is 66,000, which is 3 times the Medicaid expansion income threshold. So this is where the money's coming from. This is where the money's going to. And with that, I'll close my comments and stop sharing my screen and see if you have time or you would like me to answer any questions.
We have a question in the chat. What are congressional Democrats asking for in relation to the ACA cuts before supporting the CR?
Yeah, I
Not
think
sure what.
it's gotten to a game of hardball at the moment that they would like to see, and very intensely, an extension of that advanced premium tax credit that has made the Affordable Care Act marketplace premiums so affordable. And if you look at it, the places where in Arizona where the premiums will double or triple, many of those are represented by Republicans. Um, I've heard some comments made. There's an awful lot of MAGA voters who depend on Medicaid for coverage. There's an awful lot that signed up this last year in record numbers for Affordable Care Act marketplace. So there's a lot of people benefiting from it. They were clever in this bill of not having the cuts, at least to Medicaid, were delayed till after the midterm elections. Those midterms are November 3rd, 2026. So we have about a little over 13 months to reverse some of those things by changing who's in the majority in the party, because then you can block and repeal some of these more onerous work requirements that they're planning for Medicaid and the twice yearly eligibility enrollment and redetermination process, which would start happening in January 2027.
Okay, we have another question. Can you comment on the opinion that 7 rural hospitals in Arizona will close?
The major factor that really made us quite different as a state in stabilizing our rural hospitals was expanding Medicaid. When Governor Brewer decided to go ahead and do that. At the time, I was working for another Republican governor, Governor Martinez in New Mexico. And I think we're the only two Republican governors that stood firm and said, this is good economic development. This makes a lot of sense. It's good for the constituents who elected me. And the ripple effect of what happens when you throw a lot of people off of Medicaid is that the rural and critical access hospitals are very dependent. They have a significant percentage of the people that they see that are covered by Medicaid. If you take away 25% of that paying business, you shoulder them with basically a situation where they have to absorb more charity care, uncompensated care, and it makes it very difficult. These hospitals that were described as at risk, those 7 rural hospitals you talked about, they have margins that are maybe between 1% and 3%. There's 40% of rural hospitals in the United States that actually have a negative margin. So you can't stay open very long, the no margin, no mission type of thing. And I think that makes it very vulnerable for some of our sites. And these are good jobs. These are important jobs, but they also support the local pharmacy, the nursing home, the assisted living, the other components in the community that are particularly important in these areas that serve a very large area of our rural areas in Arizona.
Somebody asked if they could get a copy of your slides.
Sure. I've supplied the slides, and what I'll do is I'll also post them in addition to those policy briefs I mentioned on our Center for Rural Health website. I'll post them on that as well. I do encourage you to take a look. We do a lot of workforce analysis, but In addition to the slides, we just did our posted our annual report for the Center for Rural Health. And we have other policy briefs related to other issues of importance, one of which is just our horrific maternal mortality in the state, and some ideas of how we might use this Rural Health Transformation Program to improve access to not only labor and delivery services, which two entire counties in our state don't have any, but also the prenatal care and postpartum care, which are really important all the way around to improve our outcomes.
Well, as you may know, that under Medicare Advantage programs, uh, there's a there's a lot of insurance companies do require a lot of prior authorization before they can get any kind of health care or
Sure.
okay to go ahead with the physician recommendation. That's a situation that we're going to be facing under traditional Medicare since it's not under Medicare, the Medicare Advantage program as of yet.
Yeah.
And that's going to, like I say, it's going to be 6 states: Arizona, New Jersey, Ohio, um, Texas, Oklahoma. And a lot of people are not getting the information on this stuff. And I've been working with the also the state of Washington. State of Washington, I've been in touch with folks, members of Congress from the Ohio, and you know, I don't know where the Arizona Democratic delegation is on this stuff, but this is going to be. I don't have to tell you how much, how many times pre-authorization has denied people some health care.
Yeah, that was as a family physician, that was not one of my favorite things to do, is fight insurance companies for things they denied that were medically appropriate. Yeah, more than half right now just switched over in the last few months. More than half the individuals in the United States are covered by Medicare Advantage plans. Traditional Medicare is just slightly under half, and you know, we do spend a lot per capita, in this country, and yet our health outcomes aren't that good. So there's things we need to do. Prior authorization by people who are ill prepared or untrained, really, to decide what's appropriate and what's not, um, is incredibly difficult. We've certainly had state legislation, the Hospital Association and others have supported state legislation to require that when a prior authorization is there, that there's a more rapid response and a more reasonable approach to who's making those decisions. So I think you're right on target, Jane. Those are things that concern those of us that are paying attention to these types of things. And there's some of these ideas that are really bad ideas that seem to be, kind of proliferating around the state as folks try to figure out ways to control the rate of growth of costs in our entitlement programs like Medicare, Medicaid, and marketplace plans. So I think more on that. There's certainly opportunities for the state to counter those. We've certainly had an active attorney general in raising lawsuits and things like that, where these steps have gone too far and made it more difficult for people to access the care and the services they really need.
Final question is, have you spoken with our senators or House of Representatives? Are you in touch with them?
At the state level and at the federal level, from time to time, I'm asked to give expert testimony in state legislative sessions, and certainly try to inform policy deliberations through our policy briefs that we have. So as we anticipate issues that will come up before a legislative session, we try to look at unmet needs and what's likely to be introduced, and possibly have a chance for getting passed. A very small percentage of the bills introduced each year actually make it all the way through. And in some cases, when we're playing defense, that's not a bad thing. But in some of these things, there's some real work that needs to be done. And so in those ways, I do speak with state representatives and senators, often at their request to, if they need some information that we can be helpful with as far as analyzing or providing reports to help inform their deliberations.
Thank you so much.
Great. Thank you for the honor of speaking this evening. I appreciate it.